Welcome to Physician Focus with the Massachusetts Medical Society. I'm Dr. Bruce Carlin. The kidneys are vital organs in the human body, performing critical functions such as cleaning our blood and controlling blood pressure. Yet more than 20 million people in the United States have chronic kidney disease, a serious condition that raises the risk of heart attack, stroke, and end-stage kidney disease. This edition of Physician Focus will examine the many aspects of chronic kidney disease. We'll look at why it's become so prevalent, its causes, its effects on health, who is most at risk for this condition, and how we can protect our kidneys. With me for this discussion is Dr. Martin Gelman. Dr. Gelman is board certified in internal medicine with a subspecialty in nephrology, the medical science that deals with the kidney, and practices at Milford Regional Medical Center in Milford and at St. Elizabeth's Medical Center in Brighton. Dr. Gelman has been named a top doctor by U.S. News and World Report for the last 5 years and has published more than 25 articles on various topics in nephrology. He is also an assistant professor at the Tufts University School of Medicine. Welcome, Martin Gelman. Delightful to have you here.
Thank you.
We're going to do a grand tour of the kidney and its diseases. Why don't we start by saying, what are the kidneys? What do they do? Where are they? What can you tell us?
Okay, well, I'll pull out my handy-dandy little chart here and show you that the kidneys are two bean-shaped organs in the retroperitoneal space, that is the space behind the major abdominal organs. They're about 9 to 11 to 12 centimeters in length. They sit actually right by the aorta and the vena cava.
And those are the two major blood vessels
that carry
going up
blood right from the heart
the
to the body. The
outflow, and the vena cava is the return.
And so blood flows into the kidney from the heart, which is up here. The kidney acts as a filter, so there's what we call an ultrafiltrate, or a filtering of the blood, and that filtered material turns into urine, and it's then excreted down the ureters into the bladder.
Now those ureters, they're sort of hard to see. The red and the blue are the blood vessels, and the yellow there is that little ureter going into the bladder.
Tube that carries urine from the kidney into the bladder and then out as we excrete it. So if we enlarge the kidney, we can see it over here. This is a organ that I said, a blow-up, that's about average 11 centimeters in size.
About the size of, a little bit bigger than your fist.
Bigger than your fist, right.
Yeah.
This is the outside of the kidney called the cortex. This is the inner part called the medulla. And in each kidney there are 1 million filters, or what we call nephrons, that do the filtration work of the kidney. Now these are pretty much located in the cortex, a few in the inner medulla, but for the most part the filtration is in this part, and the tubules that drain the urine go down into the renal pelvis and then out, as we described before.
The renal pelvis being this
area that collects the urine from different parts of the kidney. Right.
Again, in the tan, or
this
the
is
pink.
Tan is the ureter, as we spoke here, that goes into the bladder and then out.
Okay.
So if we look at the filter of the kidney, these 1 million nephrons, 1 million of these filters per kidney, we can see that they're arranged in what's called the renal corpuscle, where blood flows into this sort of snake-like serpiginous area where the filtration occurs. Filtration then occurs through the blood vessels, gets collected in this capsule. It's called Bowman's capsule.
So in essence, what you've got here is this sort of knot of blood vessels that are a little bit leaky, and the leakiness is then collected, and that's the stuff that comes through here.
Exactly right. And then so there's this filtration of this material then goes through the blood vessels, is then goes through the glomerulus, which is part of the nephron, and then is collected in these tubules. And these tubules sort of condense the urine. They concentrate it and dilute it, and the urine then is formed and goes out the collecting duct and out, as we said. Now, if you blow up one of these blood vessels, you can see that this is where the blood is in the lumen or middle of the blood vessel.
So that's right, in coming
So
in through here.
the blood would be kind of coming right out here. There's an internal membrane. There's 3 layers to this membrane. The endothelial or inner lumen or intima of the blood vessel. Then the blue is this basement membrane.
And
then
that's like a cellophane wrapping for everything.
Exactly. And then there's an outer layer of what are called epithelial cells or kidney cells, or a fancy name, podocytes, that layer over the basement membrane. And these 3 layers actually filter the blood, and the urine then, or the filtrate, comes through here to this urinary space, which is then goes into the tubules and out. So that's essentially
a lot of steps that you skipped over there that for clarity, but basically it's a big filter.
It's a big filter, yeah.
Okay,
and that's really
and it
how
works very well.
And it works absolutely. When it works very well. Yes.
So when it's not working, how do we know about it? What happens to a patient, and how do they get from my office to yours?
Sure. Well, early on, when there's kidney damage or kidney disease, oftentimes you don't know, and that's why it's important to check. And what we check is the blood for a substance called creatinine. Creatinine is a substance that comes from muscle breakdown. Normally, the muscle in your body, some breaks down, some new muscle is formed. As it breaks down, a substance called creatinine phosphate is released, and that creatine then gets converted to creatinine. So if there's an influx of creatinine from muscle breakdown, it's the kidney's job to clear it. So if the kidney is clearing it as fast as it's coming in, there's a steady state or a fixed number for this creatinine.
So one of the normal tests we run is a creatinine.
Exactly.
To see, well, you're breaking down some muscles. So obviously a big breakdown of muscles, you can have a sudden shower of creatinine and get a
That's true, and there are
false
conditions
high.
That's right, that occur like that. What's fancy name rhabdomyolysis is a situation where you get muscle breakdown from a variety, heat stroke, a variety of things that can cause that, and the creatinine will bump. That's not a very common condition.
So in other words, in my normal workup, I always check creatinine in my yearly physical, and I think most physicians do.
It's part of a usual panel that we get.
So the first sign might not be anything that I feel as a patient, but rather all of a sudden I'm in my doctor's office and he's looking cross-eyed at a creatinine, and you're saying, what's that? So what do we do about those numbers?
Right. Well, so we look at that, and most labs now convert the creatinine into what's called a glomerular filtration rate. That is, how fast does the kidney filter and excrete this creatinine, which is the substance that we look at. The other thing that's important is to look at the urine and make sure that the urine doesn't contain too much albumin. One of the factors...
protein.
Protein, yes. We want to keep protein in the body. We want to keep protein. We use it for muscle building, for soft tissue building. It's just part of the normal building block. And so if the protein begins to leak out of the kidney, that's a bad thing. That's a sign
so the kidneys aren't doing their
that
thing.
the kidneys are not doing their job.
So in my doctor's office, I want the creatinine looked at, and I want a urine tested for protein.
Exactly, exactly. And so we've now established gradations of the amount of damage that can occur as the creatinine rises and the kidney function declines. And there's 5 gradations, stage 1, 2, 3, 4, and 5, that...
How aptly named.
Exactly. that really show the kidney is working less and less well. Stage 5 is end-stage disease where people have to go on dialysis. So we are very interested in knowing how is the kidney functioning over time. If you get a creatinine today, you want to know what your patient is doing 3 months or 4 months or 6 months from now to make sure that the filtration capacity of the kidney is not declining. Because if it is, that's a significant problem.
But I usually just test once a year. For most patients, once a year is fine.
If it's normal, then that's
fine. If it's normal, go on to the next year, or if it's a little bit off. But so there are some variations on this. If you're a tiny person, you don't have much muscle mass, maybe something that would be normal for a big fat guy like me is a little different than what it would be
Sure.
for a tiny 80-pound
That's right.
woman.
In fact, women usually have a creatinine of about 0.5 to about 1, and men have a creatinine about 0.9 to about 1.2 or 1.3, depending on their size and their muscle mass. So it does vary, but the average is around 1. And so what we want to make sure is that that is staying where it belongs and not going up, and that the filtration capacity isn't going down. So those two, the creatinine over time and the albumin, are markers of early kidney disease.
If I were to have more acute kidney disease, well, how might that show up? Because I'm going to come to a primary care physician. What symptoms typically wind their way to you?
Sure. If there's acute deterioration of kidney function, the kidney is not going to be able to filter water and salt as it normally would, and so you can start swelling up. You could start getting short of breath. That would be somewhat of a dangerous phenomenon.
But the first thing would tend to be the swelling. You just have
you'd have
swollen
swelling,
feet.
but along with that, you'd have fatigue. You would kind of lose your appetite. You'd get a little nauseous. You could even start to itch a little bit. You'd feel really pretty poor if your kidneys were working less well.
Okay, so we've got the 5 levels of disease. What are the factors that lead up to kidneys failing? What do we watch for?
Well,
what
there's
diseases?
Sure, there's many causes of kidney disease. I don't think we can go into all of them, but the 2 most common are diabetes and hypertension. 50%.
High blood pressure.
High blood pressure, yes. If you look at the dialysis population, 50% of those patients have diabetes. Another 25% have hypertension. So just those 2 diseases account for 75% of end-stage renal disease.
Of the bad progression.
Of the bad progression, right. But this starts somewhere. It doesn't all, just come down to the end. This progresses for quite a long time. I mean, you can go for 20 years or more, going from stage 1 to stage 5. Our job is to prevent that progression from stage 1 to stage 5. And we do that by trying to control blood pressure. We do that by making sure there's no infection. We do that by giving certain medications. Some people may be familiar with drugs that are called ACE inhibitors that affect the kidney in terms of hormone regulation. That is protective to the kidney. It also reverses the albumin loss that occurs. So we use those drugs quite a lot in kidney disease.
Why don't we back up just a little bit and explain to me, why should I worry about diabetes? You say 50% of the people that progress. How does that happen to a kidney? What does the diabetes do to the kidney?
Well, most people think of diabetes as a problem with blood sugar. Well, that certainly is true. We try to keep the blood sugar as normal as possible. But the real damage that occurs with diabetes is vascular damage. What happens in diabetes is that we metabolize the sugar, and we metabolize it to a fancy term is called end-glycation products. Those are the products that occur after the sugar is metabolized in the body. And those products deposit on the blood vessel everywhere. The brain, the heart, the kidney, the legs, and I think people are familiar with the idea that people with diabetes often they can lose their leg, they can get into problems of
Poorly
blood
controlled diabetes.
Poorly
We're much better
controlled.
at controlling it these days.
Well, we are.
Yeah.
But there are people that aren't so well controlled. Right. We can control it if we're in good sync with the patient. Mm-hmm. But not all patients follow their diet. Not all patients take their medicines quite as well.
Sometimes the disease is just such that it's very hard to
exactly.
Hard to
some
manage.
people are very brittle, and it's hard to control their diabetes. But even with good control, that vascular damage still continues.
And you're saying that that's related to the ability to metabolize the sugar completely, and that with the diabetes we don't metabolize the sugar completely, and it ends up as deposits on
On the blood vessels.
on the blood vessels, making them worse. And
Well, and the blood vessels in the kidney then aren't working right, and the glomerulus that I showed you sort
doesn't
of gets
filter as well.
that doesn't filter as well, and then deposits occur in that filtering glomerulus, and the kidney starts to work less and less well.
So the trick is in your diabetes, good glucose control.
We want good glucose control. We also want to make sure that if the patient is developing kidney involvement and they're starting to leak protein, we need to give them medication that will try to reverse that.
And so you're also, not only are you controlling the diabetes, but you're also doing some protective medicines for the kidney that,
Exactly.
that delay the effects of bad glucose control.
Exactly.
What about high blood pressure?
High-
How does that do it?
Well, a fairly similar situation. When you have high blood pressure, there's damage to the inside layer of the blood vessel. You saw the little blood vessel that I showed. That first little layer, the endothelial layer, the inside
the
part of the
lining.
blood vessel, that lining gets damaged. And we can bring the blood pressure down with a variety of medications that we have, but the problem is once that endovascular area, that lining gets damaged, it doesn't totally reverse. And something that has not been recognized until, I guess, maybe the last 5 or 10 years, is that even when you bring the blood pressure down to normal, that endovascular, that intimal damage continues. And so what is striking to nephrologists is that we bring the blood pressure down, everything's fine, and the kidney still shows damage. And it's that damage in the intimal layer of the blood vessel where it causes ongoing problems.
There were about 30 other things that you said also can lead to kidney failure, but I think there's only so much we can
Right.
talk about.
Right.
So what happens? You get to a certain point, and that glomerular filtration rate, I knew I could say
Yeah,
that.
good.
Is going down, 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 and now you get to that end stage disease where the kidneys aren't doing what they're doing. What do I do about it? When do I have to go get my new kidney?
Well, our job, if we can, is to get it a little earlier than end stage if we can, to try to give medications, to try to make sure that there's no blockage. And we do that by X-ray studies. The kidney actually can be saved, quote unquote, as we go, but there are many times that we can't do this. Now, what's interesting in terms of the stages is that there's about 22 million people in stages 1 through 3. There is only about 1.3 million stages 4 to 5. There's about 500,000 people, or a little less, on dialysis in the country out of this 23 or so million people with kidney disease. And I guess part of the question is, well, what happens in terms of progression that there's so few people at the
high end.
At the high end.
Or the not good end.
And the problem is that these people have a very high risk for cardiovascular disease, such that the patients who have stage 1 and 2 kidney disease have about a 43% risk of cardiovascular disease greater than the normal. But people in stage 4 and 5 have about a 343% risk over the normal. So a massive increase in the risk of cardiovascular disease as kidney
So
disease
you're saying
progresses.
that as it progresses, you don't necessarily die of your kidney disease, you die of the heart disease that's brought on by the kidney disease.
Exactly, and part of the job of the nephrologist is to manage that as well in conjunction with our cardiology friends or endocrine friends. We need to make sure that the cardiac problems are handled effectively.
We've got so much to talk about. I want to give a couple of moments to talk about dialysis and what sorts of things do patients on dialysis have to look forward to.
Well, once you reach stage, later stage 3 or stage 4, we are kind of the mind that it's very likely that these people are going to progress to need dialysis. So we want to get them ready for dialysis. Most people go on to hemodialysis. There's about 6 or 7% of patients with end-stage disease on peritoneal dialysis, which is the type of dialysis where fluid is put into the abdomen. It remains there for a while, the fluid is exchanged, and then it goes back out, and people can do that at home at night.
And so your omentum,
Your peritoneum, actually the peritoneal membrane.
The inside organs in your...
Right, there's a big membrane around your stomach and your gut, your intestines, and that membrane acts as a filter as well.
Yeah.
So if you put in clean fluid, so to speak, and the creatinine and all these toxins are built up in the blood, if you put in clean fluid, then those toxins go through through the peritoneum into this clean fluid and then exchange for a period of hours, and then we dump the dirty fluid, quote unquote.
Okay.
So that's how the peritoneal dialysis works. Hemodialysis is a filtration mechanism through an artificial kidney. We usually access the blood by doing a fistula. That is, we will take a vein and actually sew it right into the artery in the lower part of the arm or upper part of the arm, and this vein then grows to a larger caliber vessel, and we can access that.
You can mimic what was going on in the aorta. You need enough volume of blood going through your filter in order for it to work.
Right, so this is now an artificial filter, and the blood has to go through this artificial filter through the kidney machine, then brings the blood through, it filters that, cleans it, and the blood goes back into your arm. So we get people ready for dialysis by doing this fistula. It takes sometimes 3, 4, 5 months for this to grow, so we need to kind of plan ahead for that. When you're on hemodialysis, you're on dialysis usually 3 times a week for 3 or 4 hours, so it takes quite a bit of time out of your week to do dialysis. There is home hemodialysis, which is a little more gentle because people do it more frequently but for a shorter time than hemodialysis, but it requires a lot of effort. I mean, you need a partner, and it's
So what you're really saying is that this is a ridiculously complex organ to do the job of cleaning the blood and controlling your blood pressure. And so we've done various things to replace it. So we've got the filtering job done by smaller and smaller units or by artificial things, letting your omentum on your insides do it. Mm-hmm. Where are we going from here? Maybe the next step we have transplants. You can spend a minute or two talking about what happens there.
Sure. I mean, what we call renal replacement therapy is either dialysis or transplant. Now, we've come really a long way in terms of transplant. We have a lot of new drugs that prevent rejection, and so the success rate for transplants is so far better than it was, say, 10 or 15 years ago. The success rate now is about 99% the first few months, and then we take kidneys either from deceased donor kidneys. These are people, unfortunately, who have died, and their kidneys are still fine, but they usually have head trauma, and so those organs can be used to transplant into patients with end-stage renal disease. Or you can get a living-related donor if you have a family member or a loved one who is close to you who will donate. We can then plan a transplant within a few months. But transplantation has come to the point that about 90% of kidneys are working well at 3 to 5 years. So the success rate of transplant is really very good. The problem is getting a kidney. And so if you don't have a donor that can give you a transplant, then you have to go to a list where you have to wait 4 to 5 years for a kidney.
As we're going through all this, you brought up some exciting new stuff, and we don't have very much time, but why don't you tell us what's new on devices?
Sure. There's a new implantable artificial kidney, and I have a picture of that here. This is about the size of your fist. It is implantable actually in your your
Where
lower
we showed it,
leg,
right? Pretty close to,
very close to the bladder.
Yeah.
And blood comes into this artificial kidney. This is sort of a blow-up of it, and this area is a filter part, very much like the artificial kidney for dialysis. So blood is filtered here, and then there's a conduit or
conveyance
from
tube.
a tube from the area where the blood is filtered into an area that has a scaffolding where kidney tubular cells are grown. We grow the kidney tubular cells in a tissue culture, and then they're put on this scaffolding, sort of like a layer cake, and then that's put into this bio cartridge, if you will, part of the artificial kidney. So blood is filtered, and then these tubular cells reabsorb sugar and salt and potassium and whatever that they normally do, and then that is returned into the blood back to the patient, and the material that is not reabsorbed actually goes right out of this artificial kidney. It's sewn into the bladder here, and you excrete it with your urine as you normally would. So this is a new bioimplantable.
So basically, you've put a whole dialysis unit into a body.
Exactly.
With this,
Exactly.
Unbelievable. This is.
Yeah.
Do they have any problem? Well, it hasn't.
Well,
been.
this is new. This is the FDA has just approved this for clinical trials. This is developed at the University of California in San Francisco, and so this is really exciting, and we have to see how this is going to work in patients.
Might change the face of nephrology.
It could.
Well,
it really could.
This has been a wonderful tour of all of nephrology in 30 minutes with Dr. Martin Gelman, who's been a wonderful guest, and you'll have to tell us more when this stuff blossoms.
Yeah,
and,
this is exciting.
Yeah. Anyhow, thank you very much.
My pleasure.
For more information about chronic kidney disease and to view past physician-focused programs on a variety of health topics, visit our website at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Martin Gelman. Chronic kidney disease, a condition in which your kidneys are damaged and cannot filter the body's blood properly, affects some 26 million Americans. Left undetected and untreated, the condition can lead to kidney failure and even death. The two most common causes of chronic kidney disease are diabetes and high blood pressure. Patients with cardiovascular disease, obesity, and a family history of kidney disease are also at risk. Among the symptoms of the condition are changes in urination, swelling, itching, pain in the back or sides, a metallic taste in the mouth, feeling cold, shortness of breath, dizziness, or fatigue. If you experience these symptoms, see your primary care provider to get tested. The earlier the disease is detected, the more effective treatments can be. For more information, visit National Kidney Foundation at kidney.org.
I'm Dr. Robert Schreiber.
And I'm Jennifer Raymond.
Chronic diseases such as heart disease, diabetes, high blood pressure, and chronic pain are a leading cause of death and disability in the U.S.
Some 90 million Americans are affected by these conditions, and the Centers for Disease Control and Prevention reports that 2 out of 3 older Americans have multiple chronic conditions.
Traditional care of chronic disease has focused on the physician's role in caregiving, but a new model is emerging, that of patient self-management.
The Healthy Living Center of Excellence is a collaboration between Elder Services of the Merrimack Valley and Hebrew Senior Life, a medical provider with a goal of helping seniors remain independent and in the community as long as possible.
By combining expertise in the aging and medical networks, the collaborative offers a variety of programs throughout Massachusetts that encourage older adults to become partners in managing their health.
For information on how you can participate, visit healthylivingforme.org or call 1-800-892-0890.